Bob, here we go again. AHA meeting in Chicago.
In Chicago, and it's cold here.
Wasn't it kind of interesting that we welcomed the meeting with the snowfall yesterday morning? I have received so much grief from so many friends.
I kind of tell people this is how we do population control in Chicago. We bring in the weather when there's a big meeting and no one wants to actually
just so
stay
they
here.
don't get too excited, yeah.
But it's great to be here back in Chicago.
It is great, and it's great to have the AHA meeting here in particular. You know, one of the really big things happening here is that the AHA is launching this brand new mission statement, and I have it right here. It says to be a relentless force for a world of longer, healthier lives. I really think that means that the AHA is doubling down on the intent to think about preventing disease, which you and I both fully endorse.
Yeah. It's total population health. I mean, it's moving the 2020 goals to new 2030 goals and really far-reaching, getting beyond disease-based issues and moving into more health and prevention.
But I agree with that, and doing it in a way that is driven by evidence. And this isn't the first time we've been here. We know we've had the hypertension guidelines, a bit controversial, but as you and I have written and editorialized, very well positioned with very great opportunities. And we know that if we go back to 2013, 2014, we had the first iteration of the novel and very dramatically different cholesterol guidelines.
Yes.
And now they've been revisited as recently as this morning.
Just a few minutes ago,
Just a few minutes ago. So what do we know now about prevention that we didn't know before?
Well, there's always new evidence. It keeps popping up, and so now we've also got the PCSK9 inhibitors, which we can lower cholesterol to astonishing low levels without there being any evidence yet of major adverse effects. It appears to be safe. Appears to be giving us actually more effectiveness in higher risk patients to get the cholesterol lower. And I think the new cholesterol guidelines are also kind of emphasizing that although we're not necessarily talking about targets for everybody, there may be some higher risk patients where a target may be appropriate to get below 70 millimeters, 70
So what I love about the new guideline, I think it's fair to say that it was an iterative change, whereas the previous cholesterol guideline was a dramatic, almost revolutionary change. This was an iterative change that said, we are further endorsing a risk-based approach. We're further endorsing using preventive medical therapy for those at highest risk. And now we're making a stronger statement that we can better calibrate risk. And we can better calibrate risk with imaging, right?
I think that's important. Well, some things have stayed the same. In other words, the physician-patient conversation remains a really important thing to do. Okay, so that we're bringing the patient into the discussion about what we think the risks are, let the patient help us make some of those decisions. But as you point out, maybe imaging now has a role as well, because in some higher risk individuals who still have LDL cholesterols over 70 and a risk greater than 7.5, imaging has now moved up. CAC scoring has moved up to a class 2A recommendation now. And I think that's something that many of us have been following and
hoping, actually.
Another place where we've had more evidence in the last 4 to 5 years since those previous guidelines.
I mean, everyone here is hoping that the payers will respond and say, yes, we will endorse this. But like you, I now have a mature practice. And so a lot of the people that come to see me, even though I'm a heart failure guy, valvular heart disease guy, they're coming to us about prevention issues.
Absolutely.
And we're having to navigate this question of statins or not. And we know that the risk is at least 7.5% because age drives a lot of that risk.
And the CAC score itself, if we're not talking about a CT angiogram, just a CAC score, that's not expensive. It's very low radiation and it doesn't cost a lot of money.
It seems like it's almost so straightforward. Why the hesitancy, right? And we can better calibrate this risk and get people on therapies. But what's interesting about the meeting, particularly today's meeting, is yes, we've endorsed how important it is to target atherosclerosis and certainly hypertension. But now we're going into some different areas. Once again, we're going to see data later today about vitamin D. How many people are vitamin D deficient? We'll see data later today about low levels of anti-inflammatory drugs. Does that make a difference?
Yes.
And we'll see some very provocative data. You and I have seen snippets of this already about potentially a benefit of omega-3 fatty acids. So which one do you want to take?
Well, you've hit the high notes, I think. So there's the VITAL trial, which Joanne Manson is presenting. This is looking at both vitamin D and also omega-3. So there's an omega-3 component of that trial as well. And so that's going to be looking at the possible benefits of vitamin D diagnosis and treatment, as well as omega-3 supplementation. Following which, there's this other study, the Reduce It trial,
yes.
Which is going to be using kind of mega doses of omega-3 tablets in patients with very high triglycerides. Really a subset of the overall population, but we know that omega-3s are effective at lowering triglycerides. This one's then going a step further to look at outcomes.
So that'll be very interesting. And then we'll see this trial, CIRT, C-I-R-T, an NIH-sponsored trial using low-dose methotrexate for persons at high risk for atherosclerosis. I'm fascinated to see these results for two reasons. You and I both recall the CANTOS trial with canakinumab, very expensive therapy, but seemingly a real benefit, suggesting that inflammation is in the pathophysiology here. But important, we know that in the spring of this year, the NIH halted the CIRT trial, and we didn't hear anything else. Was it futility? Was it because it was already positive? So there'll be a lot of bated breath this afternoon to see what's going on.
I mean, it follows in the whole inflammation story. Paul Ridker has been leading the charge, and he's also presenting this trial. It was his thought process that maybe a low dose of methotrexate as an anti-inflammatory agent, independent of any other drugs or maybe altering cholesterol, just reducing inflammation. It does follow the CANTOS story, and again, now we're dealing with an agent which is going to be much more cost effective.
So, back to hypertension, you and I both have the privilege of serving as editors within the JAMA network, and JAMA came out with a beautiful issue targeting hypertension, not just in North America, but internationally. You can't walk away from that and not say, hypertension may be our #1 public health problem, or at least our #1 cardiovascular risk concern.
It gets back to some things we've talked about before. All the research we're doing is so vitally important. New agents, new understanding, CAC scores, everything. But if we take some things that we know already work and get them in the hands of the people who really need them, we can go a long way to reducing mortality and morbidity right away. And hypertension clearly is a target to go after.
So I think there are a couple of takeaways. For the first time, I think we can be very explicit and say heart disease can in fact be prevented in the vast majority of individuals. And the steps needed are very straightforward. Control blood pressure, particularly in those at highest risk. Don't forget about lifestyle adjustments. Be aware of the lipid profile, and in those at highest risk, consider therapies, particularly like statin therapy. The PCSK9 inhibitors, non-statin therapies, have a role, sometimes with ezetimibe leading, and then the PCSK9 inhibitor. And if there's still ambiguity, beautifully the guidelines endorse the possibility to better calibrate risk with imaging. So we can speak much more clearly now about preventing disease, about the kinds of steps needed to prevent disease, and we can be much more risk-based in what we're doing.
And these new cholesterol guidelines, of course, also bring in patients for secondary prevention. So it's not only the population-based approaches to important primary prevention, hypertension control, cholesterol control, but the new cholesterol guidelines have, updates on the management of patients who've had an event already.
So, I can't help myself. We're on the floor here at the AHA meeting, and we're in the Northwestern booth, and we're close to the front. I want everyone on Twitter to realize that come to the convention floor, come check out the booth. We might still be here. We have a lot to share with you.
Well, I hope you can see our booth here. Northwestern has done a great job at highlighting all the great things we're doing at Northwestern.
I agree.
And it's been really good because we're doing well at this meeting also. We have a lot of presentations.
Absolutely. It's great talking to you, Bob.
Thank you, Clyde.
Thanks.
Keep up the good work.